All right, so I'm Dr. Randall Gates, board certified chiropractic neurologist, chiropractic physician. We're going to talk about a holistic approach to Parkinson's today. Most of you probably know paradigms. We have the medical paradigm, which is wonderful and has many benefits. And today I'm going to talk about the holistic paradigm because some people want natural options as well. So Lizzie, let's go to the next one.
I'm sorry.
Go ahead.
No, I didn't.
Oh, okay, got you.
I was waving.
Oh, I'm with you. So, professional disclosures, I have ownership interest in Gates Brain Health, also in Advanced Imaging Reno. I'm going to talk about imaging today, and if anyone has interest in imaging, you would need to get a referral from your doctor, not me, to Advanced Imaging Reno. So, let's go to the next one. So who knows what these are?
They look like beans.
Yeah, they are. Do you know what type of bean?
Yeah, white beans. Lava beans.
They are velvet beans. And do you know what velvet beans contain?
I never heard of them.
Levodopa mucuna.
You got it. So they contain levodopa, mucuna pruriens, and that's actually where we discovered the effectiveness of L-DOPA medically around the 1960s for Parkinson's, is the way I understand it. But velvet beans have been used in ancient medicines since 1500 BC was the earliest documentation. And people in sub-Saharan Africa and many other tropical regions use the velvet bean for management of Parkinson's because a lot of people don't have access to medications like we do in this country.
They're lucky they don't.
Let's keep going. Okay, so here's a slice through a brain MRI showing this structure. Do any of you know what that structure does with the white arrow? So that is our dopamine producing center for the motor system. Other parts of the brain produce dopamine for things like cognition, emotion, motivational behavior. But this is called the substantia nigra pars compacta, and that's the area that burns out, so to speak, in Parkinson's disease, or loses its ability to produce dopamine, more specifically. This is a slice of the brain where it's diagramming the basal ganglia. Probably many of you are familiar, the basal ganglia is the part of the brain involved with Parkinson's. And big words, simply dopamine is like the gas for the basal ganglia to work. If we don't have dopamine, the basal ganglia is not able to do its job as effectively, and hence we can get slowing, we can get rigidity, we can get tremor. Everybody's different, but that's the net effect. Okay, let's go to the next one. This is just this is called the indirect pathway. It's even way more complicated than this, the way we understand it now. So let's go to the next slide. All right, and then we have alpha-synuclein. I'll be done with the big words here in a little bit. Hang with me. So does anyone know what alpha-synuclein is? Okay, so this is where we do our interactive exercise. So if you'll take this piece of paper, and you'll take this piece of paper. Lizzie, I'll probably let you hand all these out, if that's okay. There you go.
Thank you.
Perfect, thank you. So everyone can take a piece of paper. I know it seems cheesy, but it is kind of fun to understand.
What do you want me to do?
Oh, just hang on.
Oh.
Yeah. So in studying the nervous system, we want to think about, for example, if I'm going to feel something in my toe, that's actually a really long distance down my sciatic nerve to my toe. So we have to traffic proteins and other chemicals down that nerve, and there's a bunch of cellular architectural proteins that do that. So kind of think, as we now, most of us have the paper, if you were to take your paper and give it to this fine individual, go ahead and do that. So now it's like an assembly line, and you take your paper and you give it down there. You don't have to keep doing that, but you guys get the idea. Okay, now I would like for you to take your piece of paper and crumple it.
Okay.
Yeah. And then now you crumple yours. And that's alpha-synucleinopathies, as Dr. Brock described it. So then if all of you start doing that, and it's a slow effect, then that's how the Parkinson's disease process seems to start in 50 to 75% of people. Do most of you know that Parkinson's can start in your gut? Or it can start in your olfactory bulb. So Dr. Brock is a neuropathologist who found that his hypothesis is that Parkinson's may result, for those where it's not genetic, which it's not genetic most of the time, an infectious agent comes into the body, causes alpha-synuclein to start misfolding, and then that misfolding usually starts in the gut, hence why probably a lot of Parkinson's patients have constipation, or it can start in the olfactory bulb, hence why a lot of people have lack of smell. We know that lack of smell can predate Parkinson's diagnosis by a long time for certain individuals. And this slow spreading effect of alpha-synuclein goes throughout the nervous system, either up through the vagus nerve or through the olfactory bulb. Any questions? Does that make sense?
Can injuries cause it, like a bad head?
Yeah, actually, they can, yeah. Yeah. Yeah, like the NFL, that's one of the things that they're dealing with as a side effect.
Okay.
So I bring this up to illuminate. Can we go back, Lizzie, to the slice of the brain, the axial, that one. So then now that we understand that, either Parkinson's and the alpha-synucleinopathy spread through the olfactory bulb down through the brainstem, or it came up to the gut, such that then once we lose 80% of our dopamine producing ability in that substantia nigra, that's when people start to develop Parkinson's symptoms. The mainstream medical approach, you go on carbidopa, levodopa, and then other meds as time goes on. But there's a holistic approach to it as well. Okay, now let's go forward, Lizzie, a few slides. Go back to that last one. Perfect, thank you. So what Dr. Brock is showing here is that once dopamine is affected, that's not the only area of the nervous system. It doesn't just stop there. This alpha-synucleinopathy, this slow spreading effect, goes throughout the brain, which is important because we also then have to deal with other side effects like dementia and hallucinations, personality changes, depression, things of that nature. So maybe that will help you to kind of understand that it's not just about dopamine, it is affecting other parts of the brain. Okay, let's go to the next slide. This is a picture of a healthy brain cell. Over on the other side is a Parkinson's individual's brain cell looking at accumulation of alpha-synuclein. Okay, let's go to the next one. Kind of the same thing. Let's go to the next one. And this demonstrates the bidirectional relationship of the gut and the brain, which is kind of the premise of Gates Brain Health. We focus a lot on gut health because if Parkinson's starts here, everything slows down here, then lots of times we not only have constipation, but we're finding the microbiome, the 37 trillion bacteria we have in here, can be abnormal in the populations, inflammatory, and that inflammation then spreads throughout our nervous system and our body, and it might speed up this whole alpha-synuclein process. Okay, let's go to the next one. Okay, so here's my passion for a while that now we're bringing to Reno. So let's go to the next one. Okay, so most of you have probably seen a DAT scan. Yay or nay? Familiar with DAT scans? So DAT scans are looking at, how much dopamine is being brought into a certain part of the brain, and we see that reduction in dopamine in the basal ganglia for those with Parkinson's. Let's go back to the previous slide, Lizzie. So I want to highlight when all of you go in and you get an MRI of the brain, because we're trying to rule out a vascular form of Parkinson's lots of times when we order a brain MRI for someone who has Parkinson's symptoms or some other effect. This is in essence what we see. We see, there's many different sequences, but we see gray matter, we see white matter. And could we get more information from that MRI? I had exposure many years ago to these certain types of MRIs that would give you quantification. So when you go in and get a blood test, your doctor tells you what your glucose is. Wouldn't it be nice to get an MRI where you're told how many lesions you have in your brain? Not just there are lesions, there's microvascular lesions, from vascular disease how many lesions you have. Wouldn't we want to know how dense our brain is? Are we losing brain tissue? These are questions. Okay, let's go to the next one, Lizzie. And next. And next. So what we can do, and sorry this isn't super clear, but nonetheless, what we can do is we can take the MRI data, upload it to a system, and we actually get metrics for how dense your brain is compared to 3,000 age-matched normals. We can see how many lesions you have. What is really exciting for those with Parkinson's plus conditions, is Parkinson's plus familiar? So we have Parkinson's disease, and then there's a whole subset within movement disorders called Parkinson's plus. These are conditions like multi-systems atrophy, progressive supranuclear palsy, big words, but for a long time these conditions are hard to differentiate clinically sometimes because they have overlapping features. So now with the advancement of this density metric, we can actually look at density of the brainstem and say, oh, this looks more like MSA or PSP, which is really cool. So let's keep going to the next one, Lizzie. We actually keep going to the next one. We actually then can predict which type of dementia somebody might be going towards based on the pattern of loss in the brain. So as I mentioned before with Dr. Brock, how the alpha-synucleinopathy spreads throughout the brain, there's a certain pattern of spread, there's a certain pattern of loss with Alzheimer's disease as an example. So it's really quite cool. Okay, and the next, oh yeah, go back to that one. Just if you know somebody with MS, same thing, lots of times they're told you have no new lesions on your MRI, nothing new enhancing. But with this technology, we can take previous scans, upload them, and then compare them to a new scan and say, actually, you do have new lesions, or actually your lesions are shrinking. Because there's so many exciting, let's go to the medicine side, there's so many exciting medicines now for MS that we didn't have before that are reducing, I'm not here, but you know what I mean, they're exciting in what they're doing for patients. So wouldn't it be cool for an MS patient to be able to say, yeah, actually my lesions are shrinking, to actually know a certain quantification. Okay, so let's go to the next one. And the next one's initial introduction. I was going to be a high school biology teacher. I got to the end of my biology degree and I said, this is boring. I don't want to talk about mitosis the rest of my life. And so I started kind of floundering and wondering what else I could do to, you know, be of help. And I ended up in chiropractic school. And I had this interesting experience where this gentleman came to speak who invented functional neurology. And so I watched a 4-hour presentation by him helping some patients with Parkinson's. I said, that's what I want to do. 15, actually more than that, 18 some odd years later, I've been working with this and doing a lot to see what else we can do if we don't use medications. What can we do for someone with Parkinson's? Because it's not just a dopamine problem. Other parts of the brain start to wind down and are not working as well. So we do video recorded eye movements, which is really interesting because your eyes tie into your cerebellum, which is connected to your basal ganglia. So if you don't use it, you lose it. So we do eye movement therapies. We do a lot with other neuroplasticity-based exercises, gut health, micronutrient evaluations. Antioxidants are a big one for all of you. Many of you have heard of CoQ10. Should you take it? Should you not take it? It's very expensive. So I work with patients on the oxidation issue, and then holistic dopamine support is another thing that we do for those who choose to go this route. There again is the velvet bean. That's what video nystagmography looks like. And then this is a picture of when we're recording eye movements down to the millisecond. We get a graph and we can say, oh, it looks like this part of the brain is not working or another part of the brain is not working. And then, oh, this is the end video. I inserted another video of examination, but this we can play after we're done.
I do have a couple of testimonials after this.
Okay, okay, so you can play those too. Okay. So that's pretty much it. Any questions? Is that all crystal clear or really fuzzy?
I think I have questions, I just don't know what they are.
I have one.
Yeah?
What if one doctor says that you have Parkinson's and you go to another one, he says you don't have Parkinson's, and they do this, the MRI, CAT scan, nothing's wrong with you, but yet you got the tremor and the rigidity.
I know it's difficult because there's not one biomarker per se that's initially used right now for diagnosing Parkinson's. It's still a clinical diagnosis that then we differentiate essential tremor from Parkinsonian tremor with the DAT scan. So that's not uncommon, and some neurologists are a little more reticent, in my experience, to make the call early on. Others are more apt to make a call. Yeah. Yes.
I'd like to know how your approach helps people, maybe with balance or with other
yeah.
types of things, because that's what I'd like to know more of.
Love it. So Lizzie, will you go back to the VNG picture? Okay. So the reason why we, just go to the next one, yeah. So the reason why we focus on the eyes is because you have 6 muscles that control each eye. You have hundreds of muscles that control balance. The same system in the brain controls both issues. So for example, if you were to push me backwards right now, my eyes are going to go down. That's just a natural reflex. I can't control it. That's going to happen automatically. So we look at the eyes intensively because it relates to the balance mechanism. And balance and postural issues are core to Parkinson's. It's very common for individuals to get this subconscious frame of reference that they're actually falling backwards, which is why people pull themselves forwards. And that's why it's hard to initiate walking, because you may see some people when they run, they'll do this and then they go, so they take a step back and then they go. It's because we have to shift our center of pressure, is how we term it, backwards in order to walk. However, for the Parkinson's folks, they feel that generally there's a sensation that you're actually falling backwards all the time, so you're doing this and you're doing this. And if it gets so severe, we call that camptocormia, where we're so far forward. But nonetheless, I work with patients using the eye movement rehab to kind of reboot their brain, so to speak.
And how does that help?
Well, it helps because if we reboot the cerebellum and where the cerebellum perceives the person is relative to their surroundings, that can help their balance. And it's not uncommon for me to see one side of the cerebellum be a little weaker than another part of the cerebellum. So it's like having a low right front tire. Then we might veer to one side and we might have more difficulty turning one direction. I see that a lot with Parkinson's patients. Does dopamine tie into that? Yes, but
For instance, John thought, well, maybe I can do your balance exercises for your eyes. And I said, no, you can't, because maybe your
right.
Your balance has to do with another part of the brain.
That's absolutely correct. Somebody may have a low left rear
How
tire.
does he find out about it?
I have to examine somebody to know that.
You what?
I have to examine someone to know that. Yeah. So, but great questions. Yeah, I like it. I like it. Yeah.
When will the imaging center be online?
Hopefully in the next few months. So soon, relatively soon. So as you can see, we're in active construction. So yeah.
What is that MRI going to do that the mainstream doctors, the
So
difference?
all those, if you want to go back, Lizzie, to just the standard MRI slices, go way back. So that, oh, right there. So that is your standard MRI. A radiologist reads it. They say basically, do you have tumor, stroke, anything else going on medically? But that's what you get. Go to the next slide, Lizzie. So with these sequences, this is what's totally different from anything else around, particularly for Parkinson's patients, because this company has something very specific to Parkinson's.
So it shows more, right?
It shows more. It actually gives you numbers.
What type of MRI is that again?
It's the same type of MRI. It's a 1.5 Tesla MRI, but it's what we do in post-processing. So, yeah, it's very exciting. Yeah.
Okay, so John has a lot of weakness in his legs. But he does have pain in his spine or with his hips
Yeah.
and so on. So we don't know how much is related to his spine and how much is related to Parkinson's. So we're thinking about seeing his surgeon again to find out about whether it's a physical thing or, I mean, you know,
absolutely.
bone, or whether it could be somewhat helped by, you know, increase his strength by doing what you do. But I don't know if you deal with that.
I do, and that's where, when I do my examination too, I'm looking at the full picture, trying to decide, does it look like somebody has a compressed nerve? Does it look like this is coming from the back, or neuropathy? So peripheral neuropathy is actually very common with Parkinson's patients as well. And that's all throughout the literature, but it's not often discussed with your community. So that's something to look into too. So you hear about diabetic peripheral neuropathy, where the nerves start to like die and degenerate down in the legs. Well, that actually happens not as severe as diabetes most of the time, but it can happen in Parkinson's patients. And that can be part of losing sensation in the feet or burning pains down in the legs that affects balance and other symptoms.
So it could be
There's so many things.
or both.
That's why you need to do a full neurological evaluation. Yeah. Yes?
What about dystonia or muscle cramps?
Yeah, I've worked with that as well. Yeah. And so often with dystonia is kind of like the way I visualize it in some of the certain types of scans they've done on dystonic patients. You can actually see like nerve fibers intertwining. It's like the nerve, almost like the wires are sparking, and so you get a mixing of signals. So somebody goes to write, as an example, and all the muscles on the back and the front side of the hand start to cramp. But I have worked with that. Yeah.
What is the difference?
A lot of it is the eye movement therapy and vestibular therapy. If you go back a few slides, Lizzie, to the slice, the coronal slice. Are we going back? Or, yeah, keep going. Even farther, a few more. There we go, exactly. So within the basal ganglia have the thalamus. Has anybody heard of the thalamus? Thalamus is what we call the railway station of the brain. And so a lot of things going into the brain go through the thalamus, a lot of things pass near the thalamus as they go out of the brain. Well, the same area of the thalamus that your movement pathways go through, pathways from your cerebellum tied to your inner ear go through. So the ventral anterior and the ventral lateral nuclei of the thalamus are intimately tied to the cerebellum. So that's where I've had success with certain dystonia patients doing eye movement rehab, is how you would think of it. Certain vestibular exercises, trying to stimulate their brain to recalibrate.
What's a vestibular?
Vestibular is inner ear. Yeah, so it's inner ear exercises. Yeah. So I have some colleagues that actually have these devices that were initially developed for NASA, where they spin people like 360 degrees in different directions, and they do that with dystonia patients and other disorders, activating their inner ear to activate their brain. So I do eye movement rehab. You see we have people sitting up and bending over and doing all sorts of weird looking exercises. Yeah.
Okay, I got one more question.
Yeah.
If I come in, or anybody comes in for a neuropathy,
Okay.
they have neuropathy,
Okay.
and then another person comes in for just overall health check.
Okay.
Do you do the same thing for neuropathy and just a...
I don't do the same thing, no. So it's all dependent on the person's condition. The examination's the same lots of times.
That's what I mean.
The examination's the same, but then the treatment's totally different.
Oh,
Or maybe there's no treatment. Maybe it's just, hey, you look good.
okay.
Your labs look good. Your brain looks good.
Okay. All right.
Come back in a
Just
year.
curious.
Yeah, good questions. Yeah.
So I'm not quite sure how to ask this question, but my journey started with a diagnosis of chronic Lyme disease.
Okay.
So do you see other patients? Because I was told by one neurologist way back that there's some indication that a chronic illness like that might progress to Parkinson's. But early on, I didn't respond to Parkinson's medication. So I didn't take it. And then down the road, I now do respond to it, and I do have the dystonia in my feet,
Mhm,
and the carbidopa levodopa is the only thing that helps that.
Mhm.
So, just curious what your history is with that.
Yeah, I've seen a number of patients who have Lyme disease who have Parkinson's. I think what's hard about that subject for a lot of doctors is that there's no good test for Lyme disease, medically or alternatively. The backstory on it is that alternative tests for Lyme disease will basically tell most people they have Lyme disease. So if you have a test telling everybody they have Lyme disease, is that really accurate? And the other problem is, and this is from Johns Hopkins, is that the medical tests for Lyme disease miss culture-confirmed Lyme disease about 40% of the time. This is somebody who had a tick bite, we know they have Lyme disease, and the blood tests miss it.
So is it, if they have the co-infections, is that an indicator that maybe that test?
But those are also, we get into the weeds with those as well. So that's the really hard part that we struggle with Lyme disease. And then once you're past the first 30 days, people really need to be treated for Lyme disease if they're bitten by a tick in the first 30 days. But then if they don't, because a lot of people aren't aware that they even got bit by a tick or they don't think it's a big deal, then you get into the chronic phase of Lyme disease, which is really difficult to eradicate.
Well, now I don't know if I'm having a relapse of Lyme disease
Right.
or if I'm having Parkinson's.
And I've talked about it a lot in the past too, then the Lyme component creates immune inflammation. That seems to be one of the main things it does. So it sits in our lymph nodes and then it imbalances our immune system. So.
I'm curious if you know about max living chiropractic.
I'm not sure that I do.
There's only a very small, like I think there's like 4 or 5 centers in the U.S. There's one in Rockland, and we've been going there.
Oh, cool.
They teach about subluxation
Uh-huh.
in the spine,
Uh-huh,
and
yeah.
how damage in the spine can cause nerve
Mhm.
pinching
Mhm.
and affect any organ in your body.
Mhm.
So he's real bent over.
Mhm.
He's straighter now since he's been doing
Okay,
this.
good,
Um,
good.
And so, but it's in Rockland, and
Right.
we're looking for something closer.
Okay,
So,
gotcha, gotcha.
um,
Well, maybe we
what
can talk
time-
afterwards.
what the next steps are.
We can talk afterwards about all of that.
Yeah.
Yeah, wonderful.
Would you be able to make use of previous MRIs?
Absolutely.
Because I had an hour-long one in Utah.
Did you have a full body or did?
No,
Or,
just the brain.
okay, gotcha.
An hour-long, super intense,
Okay.
every detail, the whole brain mapped.
Mm-hmm, mm-hmm. And yeah, we can take use of that data and then overlap it with new data as well, or we can just look at the old data too, so.
Yeah,
Mhm.
well, that was only November, so.
Okay, yeah, we can look at that.
Yeah?
Yeah.
Okay.
Yeah. Yeah, cool. That's a long time. Yeah.
For those who have not been to a chiropractor or certainly a neurologic chiropractor,
mhm.
could you just explain step by step what happens when they show up in your office, what to expect?
Great question.
What's different and what's the same?
Mm-hmm. So what's different, I actually don't do a lot of adjusting manually as you would most think about it. I get a lot of referrals from other chiropractors who do the adjustments that you would normally know as adjustments. So there's that piece, or I may do very gentle, light force types of adjustments. But nonetheless, when people come here, it's more a standard, you sit down with me, I do a free consultation, because I want to make sure this is right for you and it's right for me. And lots of times it's not a fit. So we need to make sure it's a fit, because I really want people to have good successes out there who come through this clinic. I want them to feel better. So that's what that looks like. And then we do an examination. Usually the examination takes upwards of 3 hours. It's very thorough. We do this computerized eye movement testing, full neurological evaluation. I usually order labs. We may order imaging, not to advanced imaging, but somewhere else. And then we follow up with nutrition as well. So there's a lot that we go over, and some supplementation a lot of the time. So very thorough. And then treatment varies, just like you were saying. Some people just want to check, other people want me to follow them and manage their condition holistically, which I do for those who want that. And sometimes it's a mix. I have a lot of Parkinson's patients who are taking medications who want that added holistic side brought in. So it's not like you have to do one or the other. So,
Sometimes the medicines don't work very well.
which a lot of patients report. Yeah.
That's why holistic, I think, might be an answer to help with that.
For those who are wanting the holistic side, we're here. We're trying to bring you the most up-to-date information, and my YouTube page is an example of that, trying to get that information out there.
Is there a way to receive the pepper seed?
The velvet bean?
Yeah, the material. What is it? An extract that?
It's a good question. So there's different types of these velvet beans, and they have different names in different countries too. And so sourcing of the highest quality velvet bean and mucuna extracts is something I've worked on. Yeah.
You have it here?
I have it here, but that is very sensitive. I don't just kind of give that to anybody because they need to be under my supervision. Because they need to be under my supervision if they're taking L-dopa or mucuna, because a lot of them are taking meds and they can have side effects.
And what are the effects in a general way? I know they're different for each individual.
There can be a variety of effects. They can have nausea, really severe nausea, which most of you are aware of with carbidopa levodopa as a possibility, but it can also have other peripheral manifestations, like with blood pressure and things like that.
But I mean, the benefits.
Well, the benefits are, and okay, you bring up a really good point, and I was trying not to go here. So there is new data, I believe it's out of Japan, where they're trying to combine mucuna with carbidopa levodopa. So they're really trying to create this blend of alternative and mainstream medical. And there's one research article that I didn't attach where they're seeing prolonged effects of people's carbidopa levodopa medication using mucuna. I'm not telling you to take mucuna for the record, but I'm just saying that one study found that. But in my experience, the source of the mucuna is important, and the quantity of dopamine, the L-dopa in the mucuna, is also important. So.
Because my son is taking Rytary, and it causes all the symptoms that he has.
Well, that's
plus
where
the Parkinson.
I'm with you. And Dr. Lakshan and I have met, and I so applaud her for hosting this group and doing what she's doing. This community is lucky to have her, because there's no one simple treatment for Parkinson's. And all of us know people with Parkinson's. Many of you may deal with it on a daily basis, and there's no silver bullet for the condition. Other conditions there are. You have strep throat, antibiotics are going to knock it out most of the time.
How about stem cells? You think it can help?
Hopefully one day, but hopefully one day. And I know Dr. Lakshan is really working on bringing other advanced treatments for Parkinson's to Reno with her ties in the medical community.
Well, good for her.
Amen. Yes, good for her. I agree. Okay.
You work on diet too.
Oh yeah, absolutely. It's a huge part.
I think that's huge.
So
Yeah.
are treatments equally applicable to newly diagnosed as people who are suffering severely at this point?
Correct.
And how would your protocols vary in those situations?
It just depends on the situation, what medications are on versus what medications are not on. Yeah, I don't take people off medication, so I work with their doctor, whatever the prerogative is of the patient, and kind of meet them in the middle. So that's the hard part to understand too, because so many alternative doctors just take people down like a totally alternative path.
Yeah.
And I try to steer down the middle of that road. So, all right.
So your level of curiosity is high.
I don't sleep much.
Is I don't like it when this is what it is and there's no curiosity.
Yeah. And that's, why I'm putting in this imaging center, because I think this needs to be here in Reno. It's in the Bay Area. It's in Las Vegas. It's in LA. Why here in Reno are we going to have to wait to get this type of data for those who want it? Another 10, 20 years before somebody will do it? What I was talking about with those sophisticated brain MRIs?
Bring that imaging.
Yeah, so that's why we're bringing it here. Yeah.
Can you help a person by looking at that MRI, that one you're bringing in?
It's part of the picture. It's part of the picture for doctors to understand what's going on.
Okay.
Yeah, I wouldn't say that that's the total. Some conditions, the MRI tells the story entirely, but yeah, not in this case.
Do you have a video you wanted to show?
I think Lizzie had some testimonials, but I think we can play that as we're just kind of, yeah, meandering around. So.
And then you've got the vestibular wall here, that's
Yeah.
the vestibular tree.
Yeah.
Just kind of explain that, because that sounds like it's a real integral part.
Yeah, so that ties in, those are called microsaccades. So we do certain types of eye movements in certain planes, trying to remap the brain. So as I mentioned with Parkinson's, the tendency, maybe we won't put that right now, sorry. The tendency is to, like, we're going backwards, so we pull ourselves forwards. Well, there's a map in your brain for everything. So there's a map for sound. How many of you have seen specials on like PBS where a blind person can actually use sound or ticks in their mouth to create a visual map, almost like a sonar that bats use? It's because the auditory map grows into the visual area. Point is, we have maps of everything. If I touch your arm, there's a map for that. There's literally a visual grid system in our brain, very close to the area where dopamine is produced. So we use these types of eye movements to recalibrate certain retinal maps that are in the brain, along with the vestibular inputs going into the brain. So yeah. Yeah, cool. All right. Well, thank you, everyone.
Thank you.
Yeah, any other questions, let me know. Appreciate you coming. Yep. Thank you. Yeah.